Do you have any memories from third grade? Maybe a game of Foursquare or a field trip to the zoo? What if your memories from third grade were different? If they consisted of chest tightness and breathlessness, of sitting out at recess and trying to fill your lungs, or having to leave school in an ambulance when your inhaler couldn't calm your symptoms? For many kids with asthma, this dystopian version of school is reality. 1 in 11 American kids have asthma, and this illness causes 36,000 of them to miss school every day, making it not only a health issue, but an academic one as well. But rates of asthma vary widely across our country and highlight insidious American health disparities. Children of color suffer from asthma at rates 3 times more than their white peers. In the West Baltimore school where I'm the nurse, approximately 500 out of our 1,500 students have asthma. Notice the contrast. While nationally 10% of American kids have asthma, in the areas of Baltimore where my students live, 30% do. Of all my students with asthma, a third grader named Isaiah had the most severe case of all. Isaiah was sweet and smiley, beloved by his classmates. I learned quickly that they jostled over who got to escort him to the nurse during his frequent flare-ups. Listening to his chest through my stethoscope, I was often shocked, not hearing even a whistle of air sneak through his inflamed airways. Asthma sapped much of Isaiah's joy. Missing recess was his norm. He could never make it through a football game, and he desperately wanted to try out for the musical, but he knew he wouldn't have the stamina to sing and dance. Worst of all, Isaiah missed school, a lot of it. Anytime he got a cold or had to go to the emergency room, school just didn't seem possible. The year before I met him, Isaiah had missed over a month of class days. Here is a clear example of how one structural inequity, poorly controlled asthma, leads to another. Higher rates of absenteeism. Chronic absenteeism leads to lower academic achievement, which then decreases the chances of getting into college or a well-paying job. Addressing the lifelong impact that asthma can have on Black students is an urgent priority for our team. The traditional model of school nursing dictates that the asthma rescue medication, albuterol, be stored and used when needed at school. But for kids like Isaiah, this medicine isn't enough on its own. About a quarter of kids with asthma require an everyday medicine called a controller inhaler to keep their symptoms manageable. A low dose of inhaled corticosteroid, this medicine prevents airway inflammation. While pediatricians traditionally assume that controller inhalers will be given at home, many families face barriers that make this impossible. Isaiah's dad worked long hours as a small business owner. The pharmacy in their neighborhood was shuttered a year ago, and getting to one was difficult. The insurance company would only cover the cost of one inhaler at a time, meaning a return trip each month and no extras for grandma's house. Insurance regularly changed the medication covered without warning. One month they'd pay for one type of inhaler and a different one the next. This meant frustrating calls with the doctor's office to make the change, and perhaps another visit, for which Isaiah would miss even more school. His dad was doing his best, but the frustration in his voice was obvious as we talked on the phone. How to keep his son well when these barriers loomed in his way. We believe that poor health outcomes resulting from systemic disparities like these deserve robust intervention. There is no inherent reason why Black children have asthma at such drastically higher rates than white children in the same cities. The pervasiveness and severity of asthma in children of color can be traced back to generations of environmental degradation and economic injustice. This means it is our responsibility to create patient care models that offer reparation. Innovative models like school-based health centers, where doctors see patients inside schools, are an important way to promote equity. They ensure access to primary care, focus on chronic diseases, and offer case management. Using this equity lens, we chose to implement a new model of asthma care that had the best shot of getting Isaiah through his day wheeze-free. Dr. Jill Halterman, a pediatrician in New York, studied what happened when kids took their controller inhaler with a school nurse, a method called directly observed therapy, or DOT. Her results were just what we wanted for our kids: less dependence on albuterol, fewer trips to the hospital, and more time in school. Here was a model that promoted equity as well. Providing more services at school, where kids are every day, is one way to remove barriers for Isaiah's dad and parents like him. Families had been asking for help with asthma management since we opened, and this idea fit the bill. Here's how we did it. First, we needed everyone in our community to be on board. Principals and teachers understood the need for change since their students missed hours of instructional time due to asthma. Could they help get students to the nurse for medication each day? Absolutely, they said, quickly signing on to the idea. We engaged in outreach to neighborhood pediatricians as well, and our plan was well received by most. Pediatricians understood those barriers and were grateful for the inclusion of a school nurse in their partnership with families. Energized by this buy-in, our team moved to secure policy change. Insurance companies would have to pay for 2 controller inhalers at a time. Each would last longer, since one would be used on school days and the other at home on weekends. But finding the right person to explain this to, who could authorize the change, was one of our biggest challenges. And how to get the inhalers to school. Since transportation was often difficult for our families, we hired a delivery pharmacy. This was a win-win. The pharmacy got steady business, and families had one less thing on their plates. Nurses ordered refills when needed. Mr. Tony, the delivery man, became a beloved part of our team, and smiley kids held the door open as he came in with his box full of meds. As the directly observed therapy program grew, we assigned a staff person to administer the slew of daily controllers. This purposeful reallocation of time made good sense. If a kiddo like Isaiah came in wheezing, he could require up to 2 hours of care as we struggled to control his symptoms. In contrast, the time required to give each child their controller inhaler clocked in at only 4 minutes. So in those same 2 hours, 30 kids could take their meds and receive personalized education from our staff. These simple interventions are powerful ways to promote health equity. Providing access to a doctor at school, letting parents call into appointments instead of missing work, and ordering medications to be delivered for free. The allocation of budgets speaks loudly, and we sent a message by orienting salary dollars towards our directly observed therapy program. And guess what? It worked. For kids at our school enrolled in the DOT program, we gave 70% less unscheduled albuterol, meaning 7 out of 10 asthma exacerbations were prevented. If we could expand our program to just half the children in Baltimore with poorly controlled asthma, we could prevent around 1,000 trips to the emergency room each year. In addition, the children enrolled in DOT were in school more. On average, they missed 50% fewer days of school. So expanded access to this program in our city alone could result in 25,000 fewer missed school days per year. The projected numbers for Baltimore are staggering. Imagine then if school nurses across the country were empowered to partner with families and take such an active role in managing their students' asthma. When families needed and asked for help, like Isaiah's did, nurses could initiate DOT programs and eliminate millions of unnecessary absences. This program is effectively structured to interrupt the impact that asthma could, but need not have on kids' lives. DOT works to stop the cycle of inequity, preventing a diagnosis from impairing academic success and enabling kids with asthma to live up to their potential. DOT programs could do the same for millions of children countrywide, in cities and rural towns, down south and up north. The simple truth is that healthier kids do better in school. School nurses are a critical piece of public health infrastructure, and their potential to promote health equity is unmatched. When budgets are allocated to reflect this reality, school districts fund a nurse for each building. When kids everywhere have access to robust school health and programs like directly observed therapy, we can keep them healthy and learning. For Isaiah, who skipped in to see us every morning for his controller, directly observed therapy was life-changing. Not only did it keep him out of the hospital and in class, but the medicine controlled his symptoms enough so he could sing and dance his way through the musical this spring. We believe that every kid deserves to breathe easy and play carefree at recess, and we know how to make that a reality.